Right, we're ready. It's not a bad transition.
All right, a 77-year-old woman comes in with decreasing vision. Her right eye was her good eye. Her left eye was her bad eye because she has wet AMD. She got endophthalmitis once after an intravitreal, and then she had a macular hemorrhage one time too. So that eye is her bad eye. The right one's a good one. And for the left eye, she's on Vabysmo every 10 weeks. Her right eye is 20/25, left eye is 20/40, and her pressures are normal. Yeah, it's pretty good. It's like relatively bad. When you're used to seeing good or seeing really well, then a little bit makes you feel like you're just super good. I don't know. Okay, go for it, Khalil.
All right, this is a infrared photo of the right eye. My attention is immediately drawn to the macula, where you see these white, two large white ovoid, about this diameter and a half lesions in the macula, as well as some scattered smaller white lesions as well. Infrared to the left, it looks like white again, lesions, inferior macula, as well as central macula, about maybe combined total of 8 disc diameters worth.
Yeah, and then there's some hypo-reflective stuff in there too. And then I think some of that might be artifacts from the
Just this guy, that little flash. And maybe that,
Maybe that.
maybe, actually, that's probably not. I think usually you get the artifact toward the middle.
Okay. But yeah, good job.
Okay, this is a thing autofluorescence of the right eye. There is a hypoautofluorescent, larger than normal hypoautofluorescent area in the central macula. That's about it.
Yeah, and then those tiny little speckles of hyper, kind of like peripheral to that, but good job. And that's more zoomed in, so you can see that little.
Yeah,
Oh,
hold on.
yeah.
And then that lesion, go back to the smaller one. There was zoomed in one. So what, those dark spots, the hypoautofluorescent spots, what about the margins?
The margins are irregular. They're not
brightness. What
well
about that? Are they bright or dark on the margin?
the margins. Let me zoom in here. They look dark to me.
Yeah, good. That's super important for those types of lesions.
This is a fundus autofluorescence of the left eye. Media looks, I don't know if it's the image or the media, or maybe if she has a cataract, that makes it a little bit blurry. But you can kind of tell there's some hypoautofluorescence in the macula, kind of corresponding to those hyperreflective lesions on the infrared, and it's kind of surrounding an area of hyperautofluorescence. And there's like a couple little spots of hyperautofluorescence as well in the inferior part.
Great job, you're killing the descriptions. I'm just gonna keep going.
Okay, this is a OCT of the macula, right eye. Looks like again, pretty blurry, but I don't know if I should be commenting on the vitreous, because I don't know if that's probably an artifact or something.
Yeah, it's all, that's just.
Yeah, but the foveal contour looks normal. Inner layers of the retina look okay. The outer layers of the retina, you can see some drusen. Oh, sorry, I shouldn't say that. There's little white lesion, what they call it, hyper-reflective lesions, inferior to the RPE, kind of tenting it upwards. Surrounding the foveal area, parafoveal, and then right at the foveal area, you can see a hyper fluorescent signal, or sorry, hyper reflective signal centrally going down with a area of thinned RPE, as well as the loss of ellipsoid zone.
Can you see the arrow if I move it?
Yeah, I can see the arrow. Yeah,
I'm trying to follow you.
yeah. This is OCT of the left eye. Media looks clear. The foveal contour looks pretty deep in this one. Internal layers, you can see some stippling parafoveally. Might be like an ERM as well, starting to form on the right side of the image. The inner layers of the retina are disrupted, especially temporally. I believe this is a nasal temporal section. I'm just assuming that. You can see some disruption of the RPE and ellipsoid zone throughout, as well as some elevations of the RPE. Yep, exactly right over there, as well as some hyper-reflectance through the choroid.
You're looking for the words. David, what are these called? You're not quite hitting it.
Reverse shadow.
That's one. There's kind of an agreed on term now.
I always call it posterior acoustic shadowing, but I think I made that up.
They're called hypertransmission things now. I believe they're settled. Yeah, reverse shadowing was a while. Now they're hypertransmission. And in a lot of studies, there's all these studies on geographic atrophy and nascent geographic atrophy that are coming out, and there's like dozens of them. And there's inter-observer, and there's 9 criteria I think this group came up with that you can look at, but then they looked at inter-observer consistency. I forget what the exact term is. And the best thing are these things. So when you're looking at when you're looking at OCT, the hypertransmission defects are probably going to be the best thing for grading RP atrophy. That's most reproducible. Like we can all agree that's, like, is that a slipping or whatever, a diving in? There's all these different terms. Loss of the ellipsoid zone is a little tricky, but the hypertransmissions are pretty obvious. So those are hypertransmission defects, and the size, 150 microns is the cutoff for complete retinal and outer retinal atrophy, and less than 150 microns is incomplete.
And then just to highlight for the PGY2s, like, I like that the first thing he said is that the foveal contour is not normal, because you might look at this at first glance, and if you haven't seen a lot of OCTs, you might be like, oh, you have that kind of like little dip, so I'm good. But actually, it is more sharply V-shaped than it should be, and that's because there's a lot of atrophy happening. So this is just starting to like swoop down a little bit more. And that's not normal, and it's important for this case. I think a little bit of that was happening in the other eye, but the quality of the scan wasn't as good, so I didn't say anything. But anyways, moving on. And then
Okay.
I have a raster for you, Khalid, so I'm just gonna like slowly go through, and then we can go back.
Now it looks like there's it's an OCT raster of the right eye. Looks like there's a area in the inner retina that's completely disrupted, parafoveal and foveal, possibly a cavity there or fibrovascular tissue of some sort.
Wait, where are you seeing the fibrovascular tissue? You said
No, I'm just saying like the cavity, what it could contain on the right side. Yeah.
Okay.
I don't want to say a hole, but
You could say a hole.
okay, a hole.
Okay, yeah, that would, okay. Good. And so, and then also for the PGY2s, like when you're looking at OCTs, look at the, the segmented side, but then also look at the on-FOS side and see where you're at. And you're seeing this hole that Khalid described, and it matches, and it's in one of those spots where, and if on a real OCT in real life, like you can click and then it'll show you exactly where it matches up. So you can kind of compare it. It's a good habit to kind of just start getting used to OCT. But yeah, you got a hole. So what's your differential? I just gave it away.
Yeah, my differential, obviously geographic atrophy due to macular degeneration, advanced macular degeneration, macular hole, a lamellar hole. Yeah, it could be like if it's bilateral, it's unlikely to be some sort of inflammatory or toxic etiology in terms of like a scar or toxo, but
yeah. So like not completely ignoring, but yeah, she has geographic atrophy in the right eye. She has wet AMD in the left eye, and now she's noticing her vision in the right eye is getting worse, and there's this finding of a hole. So anything else in the rest of the room and online people can throw some other differentials out.
At the very end there, it almost looked like an ILM drape.
Yeah, okay, that's a good differential one. So we're talking about macular telangiectasia. So you could have an atrophic macular hole, idiopathic, which from what I've read just is synonymous with like vitreoretinal traction. I think. And then traumatic macular holes, macular telangiectasia causing atrophy, the ILM drape and the fovea kind of swoops down. Maybe macular schisis, you could include a pseudo hole from the ERM or the so I'm going to talk a little bit about macular holes to start with, and then we'll do atrophic at the end. But of course, you can have symptoms from the central vision loss, metamorphopsia, central scotoma. When you're in the clinic, your tech might show the patient an Amsler grid, and they may have some changes on there. On slit lamp, this is for a PGY2, not HUD. Any PGY2, you know what the sign is called when you have a macular hole. You kind of look for it, and we don't have OCT. That's a way that.
Good old days, a couple of years
Yeah.
ago.
Yeah.
Okay, yeah, it's called Watsky-Allen. So what you do is you put your beam on the macula, like straight on, and you make a fine thin beam. And the patients, if they have a hole, will perceive a gap in it. And then you can use OCT as your ancillary tests. There are two classification systems in the BCSC. One is the GAS system that was first introduced in 1988 and then modified in 95. And then there's the International Vitreomacular Traction Study, or IVTS classification scheme that came out in 2015. So I'm going to go over both of them. It's a lot. We'll go over it a little slow just because this is pretty high yield for the boards. So it actually starts, there is a stage 0 according to some people, and that's just vitreomacular adhesion. Stage 1 describes vitreomacular traction syndrome. So stage 1A has a yellow spot with the foveal depression. The vitreous has not come off yet. And then in stage 1B, there's some outer retinal involved, which I'll show you guys some pictures. That is what distinguishes it from 1A, but vitreous is still attached. Stage 2, you have a full thickness hole, less than 400 microns. Stage 3, full hole, greater than 400 microns. And then stage 4 is where it's still greater than 400, but now you have a BVD.
And one of the reasons it's modified is gas never put it size.
Oh.
That always drove everybody a little crazy. Stage 2 was not a fully developed hole, and stage 3 was a fully developed hole in the original, yeah, and it's like nobody knew what to do with that. So 400 microns nice.
All of these pictures are straight out of BCSC. So the clinical photo is showing you the yellow spot with stage 1A. And the OCT, you can appreciate this, that there is a loss of the foveal depression. And then that there's this kind of pseudocyst here, and that's from tangential traction, just kind of pulling the retina horizontally. And then stage 1B, now you have that ring, and that's because the outer retina now has some involvement. So compare that to the pseudocyst from stage 1A, there's no outer retina involved, but here it's tugging a little more, outer retina is involved.
It's remarkable he did all this without OCTs. I learned recently, someone who trained with him, because I spent time with him, but I had my own scope. But I guess a long time ago, when you worked with him, you had to share the scope with him. He had a really wide pupillary distance. Some people say that might have been helped him with all his macular
What's
stuff.
considered wide?
I'm 65, so that's normal. So I think 68 or 69.
He was also brilliant.
Yeah.
I mean,
Dang it, I don't know. if I
when you
know
talk to him, he sort of talks slow and southern,
Yeah,
because he was from.
he was very nice.
He was from the,
He's a really
but
nice guy.
he even knew my name. I was amazed, because I rarely, had interaction with him. But he was smart as a whip, and I don't know how he categorized things, but he always said, well, you have 4 cases of this and 11 of that. If you read his book, it's just amazing.
He'd go digging through his office. He'd see a patient get excited and go digging through his office for an hour and find another case.
Really? Yeah.
Yeah, something.
It's amazing.
But yes, so his eyes were very far apart.
The
I
other
just learned
thing,
recently.
the other thing he had was the old Zeiss camera. They used to do stereo on, and he must have used the stereo a lot.
Yeah, we always did stereo.
And you rarely use stereo. You're looking
I mean,
at,
never did.
yeah, so.
When we started the conference, when I started, even before you were chair, when I got here a long time ago, I used to bring stereo slides to conference.
Yeah.
I got a stereo viewer, I drop it and pass them around.
Yeah.
The stereo slides.
But that was the substitute
Yeah.
for OCT, but with those stereo photographs, he deduced a lot. It was
So anyway,
amazing.
go ahead. It's nothing.
I don't know how I would have found a hole without OCT.
Mhm.
One time I was like, fovea doesn't look right, OCT.
It's really nice,
That was the
yeah.
answer.
It's-
So this is also high yield for the boards. The chapter on this mentions it twice, the spontaneous resolution of a stage 1 hole, which is i.e. vitreomacular traction syndrome, occurs in 50% of cases if there's no ERM associated. Okay, so stage 2, so this shows a full thickness macular hole, but it's small, less than 400 microns. And then in stage 3, it's a full thickness hole greater than 400 microns.
And I think the measurement, and I've only seen this in one paper where they do it otherwise, it's the closest point. So you don't measure the base, you measure where they're closest.
Oh, okay.
Because I've seen people measure the base and I think that's just wrong.
And then for this one, I want you to appreciate that the retina is being elevated. Some of the outer retina in this one is detached compared to stage 2, where it's completely flat on the RPE. Now it's being lifted up, so that's like a little baby detachment. And then is this correct? Because I was getting confused by the OCT. To me, this looks like there's a premacular bursa or maybe some operculum floating over the retina.
Mhm.
But the
Yeah.
way they have it in the BCSC is that the vitreous is not detached. So that means it's still attached like a nerve.
Yes.
Okay.
It's a chromic classification, but they've tried to, the other one's better, but no one uses it.
So from OCT, can you really distinguish? Because I got confused between these pictures. Can you really distinguish between stage 3 and 4?
Oh, I wouldn't have called that a 4. I would have called that, I think yeah, it's funny, that's in the book, huh?
This one's called a 3.
3, that's a 3. The
But
next one I would not have called it 4.
Okay.
My understanding is that's still a 3 by gas classifications. There's not a PVD. He was with a PVD, it was a 4.
With the PVD. So then I was like, what are they looking at? Is it
Yeah,
the
that's in
operculum?
the
But then I was
book
like,
like
this is the operculum. So I was
Ugh.
just confused.
Yeah,
Okay, sounds good. All right, and then,
If you can see the poster hyaloid,
mhm,
it's not detached.
right.
Because if
I
it's
know,
detached,
yeah.
you won't see it.
on this, on LCT.
So and when you go in to operate,
Right.
it behaves as though it's attached.
Okay,
So if you see a Weiss ring and a full
Yeah.
thickness hole,
That's
it's
a
stage
4.
4.
Yeah.
Even if it's a small one, which is vexing. That's why the other one's better, but no one uses it. I wish people.
by the other one, do you mean this one?
Yeah, this.
Okay, so this is the other scale, the International Vitreomacular Traction Study one, that came out in 2013. So there are a few ways that they classify holes. This unfortunately is also in the BCSC, so we have to know them both. But the size is based on OCT. So instead of just being like small and big like the other one, which was the cutoff was 400 microns, this one gives you a small, medium, large. So less than 250, 250 to 400, and then greater than 400. You ask what is the vitreous status with or without traction, and then primary would be secondary to vitreous traction. Secondary means that there's some other pathology causing the hole. And I like this better too, because I feel like the other one just kind of gives you the stages of vitreoretinal traction and what is a tug, tug, tug until you tug it so much that there's a hole. This kind of allows space for other causes of a hole, not just vitreoretinal traction.
Well,
So it's more inclusive.
it separates out the vitreous status
Yeah,
from the whole size.
Yeah,
and it
And I
doesn't say PVD, it says traction on the
Yeah.
whole, which
Yeah.
is totally different.
So, it's actually a much better system.
and then just to prove to you that it's in the BCSC, I put the table in, so, kind of akin to the gas one, stage 0 was VMA, stage 1, was the VMT syndromes, and then this is the full thickness macular hole, the way that they define it. Okay, so a little bit on idiopathic macular holes. Remember, this was confusing to me, but these are the vitreoretinal traction ones. I think they're just idiopathic because it happens with birthdays. Maybe that's where the term came from, but it accounts for 83% of cases. The female to male ratio is 2 to 1. Usually occurs in the 60s to 80s, and if it happens in younger people, they're nearsighted. And then it's anterior posterior or tangential traction by the cortical vitreous on the fovea. And then the retina is the thinnest at the foveal floor. So as you pull, eventually, as we saw in all the pictures, the retina starts to elevate until you pull so much it just forms a hole. And then I asked this in a really weird way, but like other causes of macular holes besides idiopathic or besides vitreoretinal traction would be trauma. So like you get a blunt injury from like a car accident or something, you'll get a coup contre coup. And I just imagine like the vitreous smushing up against the retina, and then as you get the contre coup, it just rips a hole into the retina. And then the other ones would be like iatrogenic causes, where you induce some type of trauma, would be like, maybe a vitrectomy or an intravitreal injection or cataract surgery gone bad.
You get them with lightning strikes.
Oh, really?
I had a patient once, it was the weirdest conversation, because he had a macular hole, and I was like, well, where do you think it came from? I said, well, they just happened with Asians. I said, you can get them from lightning strikes. He's like, oh, I was struck by lightning. So I think it might have been a light, he was in his house, and all of a sudden the lightning hit, and he got all shocked up, and then he got worse a little later. So I just kind of mentioned it in passing. Lightning strike.
I'd like to go differential, guys.
Mhm.
Cool, okay. So for the management for these, if they're small, vitreal, tractional ones, i.e. like the VMT syndrome, stage 1, you can watch them. Why? Because the BCSC says twice that 50% of those will spontaneously resolve. Alternatively, you can inject oxaloplasmin for stage 1 holes if they're smaller than 250 microns. And that's more effective in eyes with focal adhesions as opposed to ones that have these broad-based ones. And then does anyone?
99% sure it's not available anymore.
Oh, oxaloplasmin?
Yeah, I think
Okay,
it's off the market.
cool. Yeah, I don't really know much about it.
Right. I think they got pulled.
Does anyone know what stage you would consider surgery for on the gas staging system?
Maybe 3.
2 or greater. And so you are trying to eliminate the vitreoretinal traction. So you do a vitrectomy, you peel the membrane that's tugging on the retina, and then you squish the retina down with a bubble to try to flatten it and then stimulate it to close. So
I've seen
now
people shove the ILM into the hole, and they say that helps it heal. Is that for real, or is that just something people do?
No, it's for real. So the ILM peeling, there's scores of paper, actually. I think there's probably 40 or 50 papers on ILM peeling, and the ILM peeling does help, and it's easier now with the stains. I believe the only person in my group that doesn't always peel the ILM. So if it was my eye and I had a stage 2 hole, I would not want my ILM peeled, because it's a little bit traumatic. But for stage 3 holes, the ILM peels probably help. For large holes, the ILM peels are great. So I've had 900 micron holes.
Wow.
Where they'll close with an ILM flap. So you peel it, leave a flap over it. I haven't stuffed it in, but what I do is, but people do that. It's remarkable what you can do to an eye. But what I do is I peel it, and then I just kind of, when you do your gas fluid exchange, if you don't suck it out of the eye by accident, because that's easy to do, the gas kind of lays it down over the macula. And actually, it's remarkable that it doesn't harm vision. I want to say and this is also reported, there's probably, I saw one case report of 3 or 4 where the ILM flap went bad and it actually proliferated. But I believe that's a really low risk, and I think it might, I don't know why that happened to a couple. So it's remarkable, and I've seen some of my patients where I did an ILM flap, and you kind of see it there afterwards. But it doesn't seem to adversely affect the vision. But this is all of my partners, especially the younger ones, peel ILM on every case, because it probably puts your success rate up to 100%. But I think there's a cost to it, so.
So that flap is like a scaffold for new cells to.
It seems to kind of just seal it. There's some thought, and again, people, don't have anything else to do with retina, so all I think about is retina. So there's when you talk about the gas bubble, it's probably not the pressure, it's probably the surface tension and dehydration. So it's probably that you're dehydrating the macular hole, and that's allowing it to close. And the ILM flap might it might scaffold, but it also might kind of just seal it up. Because you shouldn't have new cells growing. It should be your cells healing. It's like a Band-Aid, I guess. But it does seem to help. And there's some papers suggesting that, and again, they're all tiny papers, but there's some papers suggesting that ILM peel helps a fair amount. Regular macular surgery with nothing, on average, is about 80 to 85% if you don't mess with the ILM. But then if you do the ILM, it probably pushes up to 95%. Actually, it's not 100%, because I've had to re-op patients where they've had ILM peels. And the other thing is I hate re-operating, because if you re-op them and if they had an ILM peel, there's not a lot left to do. Then you get into all this weird stuff, which I think is kind of crazy. But go ahead.
Hey, Dr. Cohen.
Yeah.
Real quick, I was just wondering, do you take visual acuity into account before taking someone to the operating room, or do you only look at the stage of the MAC hole?
No, the patient's preference, which is kind of visual acuity. So I'll do, and I think I would operate a stage 1 hole. I generally give them 4 to 6 weeks on a small hole and just see how they do. And nowadays people use drops. Actually, Niffenegger in Sarasota was the guy who wrote that paper that was published in JAMA. Yeah, you know, John? Yeah, he was in Cleveland when I met him first, but that's another story. But he was in a group where they were hiring, and his pitch was no one's ever left the group, you know? But I didn't take the job, and I think a year later he left the group. But so it's interesting thought, but that wasn't dishonest. I think the group wasn't right for him. But he wrote an article on the drop. So nowadays, people Google it, and it's easily Googleable. So if you're watching someone with a macular, just put them on Pred Forte and Ketorolac for a month. It's not gonna hurt them. I don't know that it really helps. And
Some people, I think, used to inject air bubbles in the eye and have them go up and down.
oh,
and up and
vitreomacular
down.
retraction. Yeah, that does work. That if it's just a vitreomacular retraction, you can release. For macular hole, that probably helps some. But there's evidence that there's a relatively high risk of retinal tear and detachment when you do that, because it's a little bit abrupt. So it's kind of in and out of favor. I think it's a 5% risk of tears and detachment with the bubble, pneumatic vitreolysis.
And
So
the aquaplasmin, I think fell by the wayside because of the symptoms.
there was some retinal toxicity from it. And actually,
It's an enzyme, you're dissolving things.
what's his name?
And it's just all
Tibbetts.
part of the room.
Yeah, the guy, he was here briefly, Mike Tibbetts wrote I remember he was in the room with us, he wrote a paper on that out of Wills. And they had some vision loss from it, and it just wasn't that helpful, it was a funny drug, it seemed like it would be helpful. It just
What they
wasn't.
really wanted it for was, operating on ROP.
Yeah, I would have loved that for Pete.
But, he's passed,
Tracy, Mike Tracy.
so he stood up at the, Vitreous Society
Mhm.
and the drug had not been approved. He's hoping it would be approved.
Right,
And then he was gonna talk about the off-label use of it in ROP.
yeah,
But he stood up and he just couldn't say anything, because if he mentioned an off-label use before, they probably would have withdrawn the
Yeah.
approval.
and you
So
can't
he
talk
just
over it.
shut up, and it was the weirdest presentation, because he couldn't say anything, and he had these slides and eventually, I think the company just couldn't make money with it.
Yeah, it wasn't that useful, it just was, they had it was the side effects, and then the pneumatic vitreolysis came out, which probably was better, it was actually more effective, just put a bubble in the eye, it saves, I think our class was $8,000 or something. It had to be frozen, which was a pain in the neck, because you didn't have freezers in your office.
Yeah,
All right, so go ahead.
So are there cases where macular hole surgery is not helpful? Yes, so that was the point of this whole case, is to show you guys is that not all macular holes are from vitreoretinal traction. You can have other holes too. So in general, for the tractional ones though, outcomes are poorer. You may consider not doing surgery. You talk to your patient about not expecting as good of a visual outcome as their friend who had a hole if they had symptoms more than 6 months, if the holes are greater than 1200 microns, or if they've been there for like 2 or 3 years. Even when the hole closes, it's probably that like some of the cells died or something, I don't know, but the visual outcomes aren't as good. And then if the hole is atrophic, so in this case, the hole was atrophic, there was a lot of loss of tissue, and then you form a hole.
you had no RPE.
Yeah.
Where you don't have RPE, you don't have functional retina.
So Dr. Cohen sent me this paper that was describing full thickness macular holes in patients with AMD. And in some of them, they were those idiopathic vitreoretinal traction ones, but in others of them, there were atrophic holes, and they looked at the OCTs on them, and then they classified what they said were distinct findings in the OCTs of one class versus the other. So in the atrophic holes, all of 100% of their patients with the atrophic hole had this trapezoid shape, whereas in the vitreoretinal traction ones, 100% of them had an hourglass shape. And then there were some other parameters that they looked at, but I think it may be too much for this. And then I'll just bring up our patient again to show you, this is not a total hourglass. Not a total trapezoid, but it's not an hourglass either. And then in the VCSC ones, those ones are an hourglass shape. to show you too, so if that helps anyone, but you should always be looking at the integrity of the retinal layers to help understand what your retinal function is and what the visual outcome might be. That was the whole point, and that's it.
Right.